Many men come to us with a report of zero sperm count. It is called as Azoospermia. We recheck it, we do a sperm wash and then again go for a sperm count. If it comes to zero, then we call it as cryptoazoospermia. Most of the males have a question in their mind: would I be able to father my own children with my own sperm in case of azoospermia? We will discuss. Today's topic is testicular biopsy in azoospermia. What is testicular biopsy? What is the role of testicular biopsy in azoospermia? Can testicular biopsy help in the retrieval of sperms? What are the different sperm retrieval procedures in case of azoospermia? All these questions we will answer in today's video. Good morning, I am Dr. Rajat and you have started watching our YouTube channel, The Fertility Gynecologist. Azoospermia, like I mentioned in my previous video, is a condition in which there are no sperm counts in the semen analysis of a male. We do not do anything on the basis of a single report of a zero sperm count. We repeat the sperm count again because that sample there might be a spillage of the sample, the proper semen collection might not have been done. We repeat the semen count again after explaining the proper methods of a sperm collection. I have made a sperm collection video. Ideally, the first drop of sperm semen is the one in which the maximum concentration of sperms is there, and that spillage should not occur. So even after a proper collection, a repeat sample collection, there is azoospermia, then we go for washing the semen. And after washing, again concentrated sperms are sample looked at the microscope and high power microscope, and still we cannot find a sperm. That condition is called as a cryptoazoospermia. Now comes the question, how and what to do after a azoospermia is diagnosed. Now testicular biopsy plays a very important role in the further management. It is an intelligent basis for the further institution of corrective measures, whether to continue therapy, whether to withhold therapy, whether the sperms can be retrieved or not, and to give an accurate prognosis to a male that boss, your sperms can be retrieved or your sperms cannot be retrieved, whether to continue your own treatment or whether to think for donor sperm as an option. An accurate biopsy, testicular biopsy interpretation gives us a good reproductive prognosis and helps us in therapeutic counseling for a particular male. Testes are basically the reproductive organs which forms the sperms. The spermatogenesis occurs in testes over a period of 75 to 90 days. The process of sperm formation occurs in 16 stages. Spermatogenesis depends upon various hormones, FSH, LH, testosterone, estradiol, prolactin. I have discussed in my azoospermia video which are the hormonal tests which need to go for this thing. A study was done to conduct the results of testicular biopsy compared to the sperm retrieval. And that study said in about 51% cases of Sertoli-only cell syndrome, the sperms can be retrieved. In 83% cases of maturation arrest, the sperm retrieval is possible, while in almost 100% cases of hyperspermatogenesis, sperm retrieval is possible. These are technical terms: Sertoli-only cell syndrome, hyperspermatogenesis, and maturation arrest. I'll come to it, all these technical terms, in the latter part of the video. So, like I mentioned, a properly interpreted diagnostic testicular biopsy is critical since it helps in a pre-operative counseling for a azoospermic male. Whether, first of all, it gives a fair idea what are the chances of a sperm retrieval of that particular male. What are the success if we get the sperms to get in an IVF, to get the success of getting a baby through his own sperm. So question is, how is testicular biopsy done? Testes are the small, approximately 3 by 3 centimeter balls-like organs in the scrotum. They make the sperm in the seminiferous tubules. From seminiferous tubules, the sperm goes out to the epididymis where the capacitation occurs for 14 days. From epididymis, it goes to a vas deferens. Vas deferens goes to the bladder, and along with that, seminal vesicle and prostate, few secretions are added to the semen, and from it comes out to the penis. This is how the sperms come out in the semen of a male. In cases of obstructive azoospermia, wherever there is a blockage, suppose the blockage is in the epididymis or the blockage is in the vas deferens, then there is a possibility that sperms may be forming in the body in the testis, but they may not come out in the semen of the male. Those cases are called as obstructive azoospermia. In those cases, FSH and LH are normal, and a simple PESA, percutaneous biopsy, can be done, and subcutaneous extraction of semen can be done through a local anesthetic procedure. It takes hardly 5 minutes. A large ball needle is taken. Depending upon the site of the obstruction, especially in case of vasectomy or in case of infection of vas deferens, the sperms can be extracted. It is hardly a 5 to 10 minute procedure. Similar to PESA, there is something called as a TESA. That is also a percutaneous procedure that is done under local anesthesia. TESA is called as testicular sperm extraction. We take a large bore needle under local anesthesia. We do 3 or 4 side punches, take the material out, and directly put the material and under the microscope and look for the sperms. There is something called as, these two methods, PESA and TESA, are done percutaneous method. There is no anesthesia required, no surgery required. The advanced form of testicular biopsy is called as MESA. MESA is microepididymal sperm extraction. A small incision is put on the scrotum. Under microscope, the epididymis is seen, and just behind the epididymis, the needle is injected. Sperms are extracted, and the chances of getting sperm are more in MESA compared to the PESA. And last is called as micro TESA. The testis is open, the scrotum is open. Under a operating microscope, the surgeon takes the chunks of the testis at multiple sites, examines that under the microscope, looks for the seminiferous tubules, and at that point only the sperms are extracted. And the best chances of sperm extraction are there in micro TESE. So for an adequate, like I mentioned in my earlier part of the video, that accurate interpretation of biopsy. Now what this accurate interpretation of biopsy is, a pathologist should examine at least 100 seminiferous tubules should be examined. There should be a tissue of at least 3 by 3 by 3 millimeter, or 3 ml of tissue should be at least there. 3 millimeter by 3 millimeter by 3 millimeter testicular biopsy tissue should be there. Now once that biopsy has been done, this tissue handling and artifacts is a very common thing. An accurately taken tissue biopsy can be mishandled, and we can get abnormal results, we can get false negative results if the tissue is not handled properly, if the tissue is not stored properly. So the moment the surgeon takes the tissue with scissors, you do not have to crush it with the forceps. Directly with the scissors, you have to put into a medium. And that medium is mostly a Boyne's fluid or a Siev's fluid. We do not fix it into the formalin because they may create some kind of artifacts. This is very, very important. If you see the seminiferous tubules in the testis, if you do the total of all the seminiferous tubules in the testis, they are about 70 centimeter in length. And in various seminiferous tubules, spermatogenesis occurs at different stages in different seminiferous tubules. So when we are doing a biopsy, when we are reading a biopsy, defining the outline of seminiferous tubule is very, very important. There, the outline of a seminiferous tubule, there is a fine basement membrane which is surrounded by a collagen fibers. Outside the tubules, they lie the interstitial tissue in which there are fibroblasts, there are mast cells, and they contain the Raynaud's crystals. And just abutting the seminiferous tubule, there is a Sertoli cell which helps in the spermatogenesis. It is a pyramidal cell with a basal adherent to the basal lamina. It functions to support the spermatogenesis. And the Sertoli cells, like I mentioned, are very important part of spermatogenesis. In first part of the video, I discussed there are 5 types of interpretations of testicular biopsy. One is Sertoli cell only syndrome. One is maturation arrest. One is hypospermatogenesis. One is tubular hyalinization or tubular sclerosis. And the last is a mixed pattern. Now let us come how all these things look like. Sertoli cell only syndrome. It is also called as a germ cell aplasia. This germ cell aplasia means that there are no maturation signs of germ cells. The tubular architecture, it remains intact. There is no tubular sclerosis. And this picture resembles a case of a pre-pubertal testis. The interstitium is normal. And like I mentioned before, the chances of a sperm retrieval is close to about 50%. The next is a maturation arrest. That is a relatively better condition compared to the germ cell aplasia or a Sertoli only cell syndrome. Maturation arrest can occur at a spermatogonial level, or it can occur at a spermatocyte level. It can be because of a gonadotrophin deficiency. It can be because of a chemotherapy, radiotherapy, or nutritional factors. If that spermatogenesis is because of a chromosomal factor, then that maturation arrest at a spermatocyte level is irreversible. In those cases, the prognosis is poor. But if it is because of an endocrine factor, or a nutritional factor, or a hormonal factor, then in those cases of maturation arrest, we have got a good prognosis as far as the sperm retrieval is concerned. The third diagnosis in testicular biopsy is hypospermatogenesis. It is got an excellent prognosis as far as the sperm recovery rate is concerned. Hypospermatogenesis is a disorder in which the full maturation occurs, but the total number of germ cells are decreased. Pattern can be uniform across all the tubules. There is an increased number of small caliber tubules. The last diagnosis is seminiferous tubules hyalinization. If there is a sclerosis across all the seminiferous tubules, there is a peritubular hyalinization. Normal tubules are not prominent. Even Sertoli cells are not prominent. And this has got a worse dismal prognosis. The chances of sperm recovery is zero in this kind of cases. Out of all this, the most common pattern is a mixed pattern. That means in a testis, there may be at some places Sertoli only cell syndrome, at some places there would be a maturation arrest, at some places there would be a hypospermatogenesis. In some cases, hypospermatogenesis may be more, maturation arrest may be less. And this is the most common pattern which we find in the reports of testicular biopsy. Johnson made a criteria in which 100 seminiferous tubules are counted and a grading of a testicular biopsy is done regarding the diagnosis. However, this grading is not accurate because, like I mentioned before, spermatogenesis is not occurring at same rate, at same stage in all the seminiferous tubules. Spermatogenesis goes through 16 stages. In first, it may be at spermatocyte stage, it may be at spermatogonia stage, it may be at primary spermatocyte stage. In some tubules and different tubules, it occurs at a different level. So there should be a systemic approach to a testicular biopsy as far as a pathologist is concerned. And that pathologist should be an expert in doing a testicular biopsy report. Initially, a low-grade microscopic examination is done. The first thing we look at for the heterogeneity of the sample. Then we look for the tubular diameters, seminiferous tubular diameters. A decrease in tubular diameter is suggestive of a damage to the tubular epithelium. We also look for the intratubular dysplasia. Then we go to the interstitium. We look for the interstitial edema, we look for the fibrosis, we look for the granuloma. Then we look for intertubular tissue for the presence of Leydig cells, whether they are present, and that should be done at a higher magnification. Then we come to a high power examination. This was a low power examination. Then we come to a high power examination of the germ cells. We look at what stage the spermatogenesis is occurring, and then we are able to make the classification whether it is a maturation arrest, whether it is a Sertoli only cell syndrome, whether it is hypospermatogenesis. So in conclusion, I would like to say for azoospermic males, the first diagnosis should be whether it is an obstructive azoospermia or a non-obstructive azoospermia. If FSH-LH is normal, then the likely diagnosis is an obstructive azoospermia. In obstructive azoospermia, in most of the cases, PESA or TESA or MESA, it gives good results. The sperms can be harvested. This is all. The sperms extraction is easy. We can directly freeze the sperms at that point of time. But if it is a case of a non-obstructive azoospermia, NOA, we have to rule out whether it is a primary testicular failure or a secondary testicular failure. Even if FSH is high, in few seminiferous tubules, spermatogenesis is going on. Sperms can be recovered. a properly conducted biopsy with less or a minimal tissue mishandling, with a correct interpretation by an expert pathologist who is doing in good work in enterology, helps us in better preoperative counseling, whether to continue the treatment, whether to withhold the treatment, or to give a clear idea to the patient ke boss whether your sperms would be available or not, whether the pregnancy can occur with your own sperms or not. Even if we retrieve the sperms by TESA, MESA, PESA or micro TESE, the answer is only IVF. Those sperms can only fertilize through the IVF test tube baby only. There are no chances of a natural pregnancy. So this was our short take on role of testicular biopsy and in azoospermia and various sperm retrieval procedures. Please like the video, please share the video, and please subscribe to our channel. If you want to